This is Selma Schimmel for the Group Room in Chicago, where we are at the 2012 Multidisciplinary Symposium in Thoracic Oncology, which is brought to you by ASTRO, IASLC, ASCO, and the University of Chicago. I'm very happy to welcome back Dr. Suresh Ramalingham. Dr. Ramalingam is Professor and Chief of Thoracic Oncology and Director of Medical Oncology at Emory University Winship Cancer Institute in Atlanta. Welcome back.
Thank you, Selma. It's a pleasure to be with you.
So our discussion today is going to focus on a very specific area with you. We're going to move into an area of a compound that we call PARP inhibitors. And some of our listeners may have heard about PARP inhibitors for breast and ovarian cancer, but today we're talking about this expanded use in the area of lung cancer.
Absolutely. PARP inhibitors are a group of compounds that are now entering phase 2 studies in lung cancer, and we're beginning to understand a lot more about how these drugs work and what the biological role of PARP and its members and the members of the family of PARP proteins do in cells. I think at this point what we're at is trying to understand how PARP inhibitors can be integrated into our current treatment paradigms for lung cancer. There are other tumor types where certain mutations, like the BRCA mutations, that confer sensitivity to PARP inhibition, where you can give PARP inhibitor if somebody has a cancer and the BRCA mutation, where promising results have been seen. But in lung cancer, we don't see BRCA mutations very often. So it's unlikely that you're going to just give a PARP inhibitor to a lung cancer patient and expect it to work by itself. Where we think these group of agents are going to fit in well is combination strategies with radiation, with chemotherapy, and perhaps with some of the other targeted drugs. And we're understanding the biological rationale for each of these approaches in greater detail as we understand the biological functions of PARP better. Let me take a step back and say where PARP inhibitors are likely to fit in lung cancer. We know that patients with EGFR mutation benefit from EGFR tyrosine kinase inhibitors. We know that patients with ALK translocation benefit from ALK inhibitors. But there's a large subgroup of patients, I would say 60 to 70% right now, where they either do not have a specific mutation that we can go after for treatment, or they have a mutation and they have gone through these treatments but have become resistant to therapy. So for those patients, the conventional treatment approaches such as chemotherapy and radiation are considered the mainstay. So the PARP inhibition strategy is now focused on those patients to see who among those subgroup would have a tumor that's exquisitely sensitive to the combination of PARP inhibition with chemotherapy. So we're doing the trials for those 70% of the patients right now with the explicit focus of identifying who among them will benefit in the next set of studies.
So at this point, how do you decide which of your patients you would like to give a PARP inhibitor to?
If you look at where PARP may be very relevant in a cancer patient, it is in the setting of administration of agents that target DNA. So if you look at how radiation works, it causes DNA damage. And when you induce DNA damage, the cells either repair it and go back to what they were doing, which is multiplying, or they find that the damage is too much and shut down and die. So what we're trying to do is to prevent that DNA repair in those cancer cells by adding a PARP inhibitor. So trying to introduce lethality to the cell by destroying its defenses against DNA. So platinum compounds, which we use in lung cancer quite a bit, they work by basically causing DNA damage. Radiation does the same. So right now our trials are focused on combining PARP inhibition with platinum-based chemotherapy in patients with, say, non-small cell lung cancer who don't have an EGFR mutation or ALK inhibition.
What phase of research is this trial in?
We have 2 phase 2 trials that are ongoing in lung cancer with veliparib, which is a PARP inhibitor that's developed by NCI and Abbott. One trial is in non-small cell lung cancer. These are patients who are considered candidates for platinum-based therapy, and we randomize them to either giving chemotherapy with placebo or chemotherapy with a PARP inhibitor. Again, these are randomized phase 2 studies. typically accruing about 150 patients. But one of the important goals is to collect tumor specimens from every one of these patients so that we can go back and look at specific markers. We have some clues as to which markers might help, but we have to validate that in patients.
Before you leave me, we've only talked about non-small cell lung cancer, which we tend to do because there's not a lot to say about small cell. But if you have any comments about, for our small cell patients who always say, you know, there's no content for me.
As we were talking about PARP inhibitors, actually at the Eastern Cooperative Oncology Group, this week we're launching a trial with a PARP inhibitor in patients with small cell lung cancer, which is a randomized trial with about 150 patients, again phase 2, not very different from the non-small cell lung cancer trial we talked about. And we hope that PARP inhibitors may actually play a role in small cell lung cancer. We have also at ECOG completed a large randomized trial looking at 2 new classes of compounds. One which is a hedgehog inhibitor, that's a targeted drug used in basal cell carcinoma, and another compound that targets the IGF-1R pathway. We hope to find the results in the next few months from this trial. So we have some promising leads. And in the molecular arena, we're also now understanding some of the dominant drivers that are driving small cell lung cancer. This week in Nature Genetics, there were 2 papers published on small cell lung cancer and its molecular characteristics. So we're now finding targets in small cell lung cancer. Again, it's not fast enough for our patients, but we see some bright spots that we can hopefully translate into reality and improve therapies for our patients.
Thank you. It's great to see you again, and I appreciate your time.
Thank you, Selma. I appreciate the opportunity to have this conversation with you and with your viewers. I look forward to being here again another time.